Hello there. My name is Jonathan Friedman, and you're listening to FAQs by EHN Canada. This is a show where we scour the internet for the most frequently asked questions about mental health and addiction and ask an expert for their answers to them. Today, it is my honor and my pleasure to introduce our guest, Dr. Ramasubbu. Dr. Ramasubbu is a licensed medical doctor with the Royal College specializing in psychiatry. He is contracted with the Department of National Defence, providing psychiatry assessment and follow up to support active members of the Canadian Armed Forces. Dr. Ramasubbu also provides trauma informed, evidence based care, formulating through a biopsychosocial lens to diagnose and treat well deserving service members. Dr. Ramasubbu, how are you doing today?
I'm doing very well, thanks, Jonathan. Thanks for the lovely introduction. It's great to be here as a guest on your show today.
I'm really I've been looking forward to this one for quite some time. Really excited that you're here. I asked this to all of my guests because we have the formal bio, but I love hearing like of all the fields in the world, you're a super smart person. How did you end up in psychiatry?
That's a great question, Jonathan. And maybe before we get too far in, I just want to mention for our lovely audience as well that, any content shared today on today's podcast is general information only, and it doesn't constitute any medical advice. Of course, any views expressed here are my own and don't represent any opinions of employers or affiliated organizations. And just for everyone to know, I don't have any conflicts of interest or financial disclosures to note. So let me tell you a little bit about my passion for psychiatry. Of course, it's obviously an important question in terms of where I am today, how I got here. I think I've always been interested in mental health, and really at the at the core of mental health is understanding that, we're all vulnerable to suffering and to pain, and being able to help someone at their most vulnerable is a privilege um, that, kind of keeps me fresh, keeps me interested, keeps me excited about helping people. Um, and so psychiatry, I think I'm always interested in the story and the experience. And I'm very fortunate to be in a position where I'm helping well deserving Canadian Armed Force members explore their mental health and with the goal of improving their quality of life and function.
Were you always working with service members?
No, so I initially started off after finishing my residency in Ottawa. I started a private practice, a group practice with colleagues in the community, and it was actually those experiences in my first couple of years in practice that really led me to really appreciate my passion for helping those who've experienced psychological trauma. I think again it goes to my just natural curiosity of, you know, how we go about our day-to-day and life experiences and how they shape us, how they can empower us, and how they can also challenge us. And so I found kind of a niche here working with this um, special population and really tapping into the vulnerability that doesn't always present itself so voluntarily, if you will. Yeah.
Super cool. Trauma is really what we're going to be diving into today. So I'm really excited to have you on the show to discuss that. Going to be talking about trauma. We're going to be talking about PTSD in general, but also specifically about how it relates to those who serve our country. So um, for me, I know, especially since COVID, mental health is, a bigger discussion on the internet and my own discussions, even with my friends, not in this space. And
Right.
I'll hear all the time, "Oh, that thing gave me PTSD." We hear it a lot,
Mm,
but what does it actually mean?
that's a great question, Jonathan. I'm glad we're starting here because I think what's becoming more and more common in society now is we tend to use a lot of 3 or 4 letter acronyms without really appreciating the full scope and magnitude of what it means. And the consequence of that is it can dilute the significance of those who may actually be living with, clinical symptoms of an illness. And so PTSD stands for post traumatic stress disorder. And it's one of the featured diagnoses in our chapter of trauma and stress related disorders in our diagnostic manual. Currently, we're using the DSM 5 TR, or text revision. And that's sort of a standard manual that helps as a guide for diagnoses. Um, so, this being a featured diagnosis in the chapter, to be diagnosed with PTSD, Jonathan, one must first be exposed to major trauma. What is major trauma? Major trauma is exposure to actual or threatened death, serious injury, or sexual violence. And it's important to define what exposure means. Okay, so it can manifest in different ways. It can be experienced directly, it can be witnessed, it can be learned that it's happened to a close family member or friend, or it can be something that's experienced in a workplace setting with repeated or extreme exposure. And a classic example is what our first responders are exposed to on a regular basis. And so, if one of these exposures is met, there are a number of other diagnostic criteria which is needed to substantiate a diagnosis of PTSD. Categorically, this includes the presence of intrusion symptoms, so unwanted memories of past trauma, which can happen during the day. It can happen in flashbacks. It can happen in nightmares. So, those are some examples. The presence of avoidance. So, extreme efforts made to avoid either thinking about trauma or any external reminder. So, that can be people, places, conversations. So that's another hallmark feature of PTSD. And then, of course, the changes that can take place in the way we think and feel. So, a trauma experience can, alter the way that we think about ourselves or other people or the world. We might become more detached from other people. We might have a harder time experiencing positive emotions. Those are just some examples. And then lastly, the presence of significant changes in the way we regulate our nervous system, our arousal and reactivity. So what that might look like is, extreme irritability and anger, reckless behaviors, um, reduced concentration, sleep disturbance, etc. So it's quite there are a number of features, of course, and categories to navigate, and that's what makes it fairly complex as well.
Thank you for that. And I think one of the pieces that I run into on the show and in conversation is a lot of disorders are things like they have features that are very human to experience. In our day to day, unfortunately, we all might experience something that's distressing. In the case of anxiety, we all experience some level of anxiety. We experience sadness, but that's different than major depressive disorder or post traumatic stress disorder. These are so. I guess my question is, what differentiates something from being a disorder versus being just a human emotion or experience?
Mhm. Yeah, I think you're absolutely right in that, as human beings, we all have the propensity to experience the wide range of emotions, which are normal and normative. And so, as you mentioned, anxiety, normal, sadness, normal, anger, normal. Um, what really constitutes a disorder and illness is the degree to which these emotions are experienced in a way that might impair one's function or cause significant distress. So, I think it's really important to distinguish, for example, the difference between grief and depression, clinical depression, right? So, um, being sad after loss is normative, right? But if that sadness manifests in ways that are prolonged and it can impair function, then it's something that might suggest, it falls outside the realm of what's considered normative grief. And that's just an example. Um, yeah, I think that, when it comes to, as you mentioned, how we experience, our feelings, our thoughts and feelings, unfortunately, um, about 75% of Canadians actually report experiencing major trauma in their lifespan. So those exposures that I talked about earlier, it's fairly commonly experienced. However, only about 10% or so of Canadians will meet criteria for PTSD in the general population, and about 20% um, of active Canadian armed force members and veterans experience PTSD. So it just goes to show that, even in the context of being exposed to major trauma, not everyone develops the clinically significant symptoms and signs that would suggest an illness.
So why is that? So let's say in service, um, two people experience the same event, but one person might experience PTSD as a result, and the other one might have just experienced a traumatic event. Why would one experience or receive a diagnosis for PTSD as a result of that, while the other won't?
Great question. And difficult in that you're absolutely right. Not everyone will develop the same or have the same experience of trauma. And that's what makes it a very heterogeneous diagnosis as well. Not everyone presents the same way after experiencing trauma. So there are specific characteristics, and it has to do sometimes with not just the nature of an exposure to the type of trauma, but also some individual factors, Jonathan. So we know that certain risk factors that might predispose to developing something like PTSD are certain risk factors that are non-modifiable. So if you're looking at, female sex, for example, is something you can't modify. Um, but there are other factors that you can, when it comes to managing other mental health conditions that might be experienced. Um, you know, some Another factor that's important to look at is the presence of childhood adverse experiences or trauma. We know fewer years of education can correlate to increased risk of PTSD. And of course, the difference between one exposure to trauma versus recurrent exposure can also increase risk. Separate to that, how people cope in general. There's healthy ways of coping and less healthy ways of coping that can affect whether or not one, might develop PTSD, as well as the quality of their sleep. So sleep disturbance is another kind of independent factor. So there are also protective factors, right, that are worth exploring. So if we have healthy, adaptive ways of coping, healthy outlets for stress, that can reduce risk of developing PTSD, as well as being socially connected. So having a good social network, a good social fabric can be protective against PTSD. So when someone has experienced major trauma, the degree to which they're able to access help and feel validated in that experience can really influence whether or not they may develop post traumatic stress symptoms versus, exposure to trauma, which is well supported and managed before it becomes more impactful.
There are two really interesting pieces I want to talk about before we talk about treatment. One is coping. You mentioned healthy coping and unhealthy coping. I'm wondering if
Yeah,
we could go a little deeper and define what healthy versus unhealthy coping would be.
absolutely. Happy to. And I specifically chose those words, healthy and less healthy, because I think so many people, so many of us, we're prone to um, being hard on ourselves, being very critical of what we do. And I often hear people will say they're coping poorly or they're doing bad things. And I really believe everyone does the best they can. And so sometimes unhealthy coping can be the avoidance of getting help, right? And we might, in terms of treating conditions like PTSD, where they may not present so visibly as someone who has, a fractured leg or arm might present. Sometimes the nature in which we go about our day to day is very avoidant in general. Society leans into some of that avoidance. When you pass someone on the street, hey, how are you doing? Good. How are you? Is that true? Or is that more just kind of a commonplace gesture, right? So the less healthy ways of coping are often embedded in some form of avoidance. Um, maybe individuals might use alcohol or substances to try to suppress symptoms that are causing distress. Maybe they're using sleep as a way to avoid feeling. Maybe they're taking daytime naps, or maybe they're over investing into work as a distraction, but it becomes less healthy when it's really the source of coping. There's no balance. So even things that are healthy can be overdone and overconsumed. Another example might be food, overeating. So any coping mechanism that is used in a way to suppress uncomfortable thoughts and feelings might be considered less healthy versus healthier ways of coping, such as exercise, mindful nutrition, schedule and routine, sleep, you know, um, getting help, when you're feeling unwell. These are all ways of addressing an issue and externalizing those symptoms that are causing suffering. Mhm.
So, in the example of work and routine, if we're struggling, having routine and order might actually be a really, really healthy and important thing. But over investing in
Absolutely.
work as that example, spending 60, 70, 80 hours, an example might be that you're using that to avoid sitting alone and having those uncomfortable thoughts.
Absolutely. Very well said. And I think that's important to talk about the protective elements of employment as well, and that's why we really encourage, in any condition that's diagnosed, management and functional recovery. The protective elements of work are the routine, the structure, the schedule, the sense of purpose, and the mastery that comes with that. So when you're removed from the work environment, um, it can be very difficult. It can be very disruptive to one's sense of schedule. And one of the first things that are subject to decline is just our sleep wake schedule, because there aren't those parameters that we commit to. And so, absolutely, when it comes to coping, there are healthy ways, less healthy ways. And part of treatment is really looking at maximizing healthy coping and trying to increase a sense of self efficacy in being able to reliably self soothe from uncomfortable thoughts and feelings versus avoid.
The other piece we spoke about and touched on is sort of non-professional social supports. So, family, friends, community supports. How do these play in recovery and supporting people who struggle with PTSD?
Yeah, great question. I think anything, you know, any sort of mental illness affects more than just the individual experiencing that illness. It can absolutely impact, the family, friends, community, in a professional setting. And so I think it's really important that, family and friends also play an important role in the recovery aspect. So the first thing is recognition, right? And we know negative reactions like disapproval, lack of understanding, um, correlate with increased significance or increased intensity of PTSD symptoms. But on the other hand, positive reactions, so having supportive interactions with family and, basics, Jonathan, like attentive listening, validation, and reassurance, all of these promote resilience. So it's like, you want to empower an individual to um, to feel like they can get better and they're not dealing with their illness in isolation or on an island. I mean, we are all connected. So supporting daily activity, getting outside the house, supporting connection. These are important factors that family, friends, colleagues can play. And again, important to note that, family and friends might also be subject to vicarious trauma or carrying the psychological burden of living with someone who's struggling with PTSD. So it's also important that you encourage those to seek their own individual help as well, because it's important that the classic cliche of putting on our own oxygen mask before we help others, I think is so important here. And far too often, I think we're so good at helping other people, or at least making the effort to listen and support. But to what extent do we do that for ourselves? So those are things that family and friends might consider.
Interesting. And I guess where my head goes is I imagine that engaging and trying to create activity and systems in the home with somebody who might be, avoidant or shutting down, that individual who's struggling with PTSD might not actually want to leave the house and, go do a fun activity with the family, which I imagine can be pretty frustrating for, the family member who's trying to connect and communicate. What's your advice or thought around how to how that individual might take care of themselves so they're not, taking it on, getting really frustrated with their partner or their kid?
Yeah, that's a tough one because again, I think we all experience pain and suffering in different ways, and it's hard to see a family member, loved one struggle. And sometimes we want to find an immediate answer or resolution. I think being mindful too that, PTSD is a diagnosis that's made based on something external happening to the individual. It's not a condition that originates within, it's contingent on exposure. So it's something completely removed from the individual's control. So recognizing that, you know, in spite of efforts to want to encourage activity and connection, individuals suffering from PTSD, there's a natural tendency to withdraw, to be more closed and feeling detached. And it's not personal, right? I think that's ultimately the important takeaway is it's not a resistance to treatment. It's actually part of the illness. So patience uh, is key, but also difficult. So, maybe engaging in conversation, with the individual to really understand, you know, when is that when is the individual asserting themselves and maybe responding to a healthy bodily signal or cue versus avoidance. So I really try to tap into, you know, are you uncomfortable doing something because you're self-aware? Are you not feeling well that day? In which case maybe it's good to not, you know, do an activity that could potentially make you feel worse. And there's a difference between being self-aware and being selfish. So someone who's self-aware might be attuning to the fact that today's not a good day. Maybe they're waking up with a headache. And actually it's good for them to recognize that and integrate how they're feeling with a behavior, right? So if they're not feeling well and they decide, I'd really like to do this coffee hangout, but let's reschedule. I'm feeling off today. There's an intent to want to engage, but also kind of an assertiveness as well in a respectful manner. So that's very different from, someone um, who isn't maybe aware of what they're feeling, but making the same decision, and that might be seen as more avoidant, right? Like I'm just not going to go, but there's no real reason for not going. So I always support people in making decisions that are based in sort of self-awareness and self-discovery, because part of trauma recovery is regaining a sense of control with one's thoughts, with one's body, etc. And part of that regaining agency and autonomy is being able to sometimes say no. And that's a healthy thing to do. So being family, I think, again, just inviting conversation and dialogue about what might be like a healthy reason to not participate versus avoidance and really being patient in that process. I don't know if that
I think that's a really good
makes
distinction.
sense. Yeah. Mhm.
Yeah, I think my takeaway so far from our conversation is that that is self-aware versus selfish. I think that's something I can really latch onto, um, because it is important to take a step and say, "Hey, you know what? I'm not feeling good today. This is something that um, is not something I want to do today. I don't want to go for coffee today. I actually want to take some time and reflect and think and just have that time for myself." Um, Whereas sometimes that shutting down or that kind of behavior might become a pattern that I might want to address. So really appreciate that. Thank you.
Mhm.
So we spoke about non-professional supports, um, being a psychiatrist and being a professional support. I'd love to take a look at what treatments exist for PTSD. Obviously, one size doesn't fit all, and different treatments and different groups of treatment might work differently for different people. But I'd love an overview and an understanding of what treatments exist for PTSD and what are you curious about? What's coming up in that world?
Mhm. Yeah, no, that's excellent. And certainly, you know, uh, part of my job I really like most is okay, after we've reached a diagnosis and we can make clinical sense of what's going on, what can we offer people? And, I start by mentioning PTSD is not a terminal condition. Okay. It's a chronic condition that can be managed. And I think that's a very important distinction, right? For those who hear PTSD and they think, this is something that they can never overcome. I don't believe that to be true. It's certainly not why I'm in this profession. Um, so when we're looking at treatments, we're looking at what's evidence-based. Okay. So I refer to our Canadian practice guidelines, and it's very clear, combination of medication and individual therapy provide optimal uh, treatment response and with the goals of improving quality of life and function. So the essence of treating trauma is trauma focused psychotherapy, and these are considered first line treatments for PTSD. I'll give you some examples. So prolonged exposure, is a type of therapy where you undergo repeated controlled exposure to trauma memories and reminders with the goal of reducing avoidance and any sort of distress, emotional distress or physiological distress. Cognitive processing therapy. This really looks at identifying and restructuring trauma beliefs that are distorted. Again, when we experience trauma, sometimes the way we understand ourselves or others, the world, we see things in a different way. And cognitive processing therapy helps restructure those thoughts. And then EMDR, or eye movement desensitization and reprocessing. This is a type of therapy that combines both exposure and cognitive restructuring with the use of what's called bilateral sensory stimulation. So classically, that might be eye movements, and that's another trauma focused therapy. So those are the mainstay treatments of PTSD. And, without getting too technical, there are medications as well that are prescribed. And I think of medications as an important complementary piece in treatment, particularly in stabilizing symptoms. What do I mean by that? I think of medications as helpful in lowering the distress signal when you're experiencing heightened anxiety, depressive symptoms, etc. It kind of reduces the volume of those symptoms. So it allows you to have better control of your, immediate surrounding. If you're disoriented in time and space and you don't know left, right, up, down, think of medications as an anchor. Okay, it's a grounding position, but that's insufficient to treat the emotional salience and significance of trauma. And that's what is re experienced in PTSD. So, if we're looking at medications, we look to stabilize some of the core features of PTSD, but we also pay particular attention to things like sleep disturbance or nightmares. And we have, secondary targets for treatment to try to lessen the burden of those as well. And then more broadly speaking, PTSD often, doesn't often exist independently, right? It tends to cluster with other conditions. So if there are physical pain conditions or head injuries, addictions, making sure and ensuring that we have adequate treatment and supports for those uh, other illnesses and injuries are important. Even looking at a practical day-to-day functional approach, there may be a role for occupational therapy to assist with activities of daily living or helping people kind of function in their independence. And that's well recognized as being the sort of, we'll call it biopsychosocial approach to treatment. And as you mentioned, it's not a one glove fits all. Treatment is tailored to the individual. Um, and so that's kind of our standard in terms of what we prescribe and what we recommend. Emerging modalities. It's so difficult, Jonathan, because we want to give people our best, and sometimes um, what's new and upcoming garners a lot of attention, right? And in evidence-based practice, often our guidelines, take time. We need evidence to prove that, new modalities or treatments are clinically safe and effective, right? Because otherwise, how can we predict response? So, some of the more emerging treatments like neuromodulation, ketamine assisted therapies. They're um, sometimes offered in more experimental or academic settings. Unfortunately, we just don't have the full rigor of evidence at this stage to recommend them um, in terms of our usual standard treatment protocols. Individuals might find access or maybe benefit if all other avenues that are well evidenced have been exhausted, but typically practice for treating PTSD is really looking at a combination of psychotherapy and medications.
I think that's really comprehensive, and it makes a lot of sense. And I think that you look at the news and you'll see something like ketamine assisted therapy, and you're like, wow, that's interesting. But it's important to know that when you're going to a psychiatrist or going to a doctor, they're looking at you, looking at your system, and looking at what has years and a history of evidence to support you and that system, and to monitor and go through that with you to a place where you're experiencing recovery.
Completely. Absolutely. And, first do no harm. So I trust in our guidelines because you know, they don't they're not based on anecdotes. They're not based on, one person's experience or a friend's experience. They're based on populations. And that's reassuring in that even if one medication or one therapy may not work for an individual, I'm confident that, another will, right? Because generally speaking, that's our approach, right? And if we're not achieving optimal success, we also have to be curious, right? And I think clinically, like, is there something we may be missing, right? Are we trying to treat a symptom which may not respond to medication, right? Have we fully accounted for all the social factors? So, for example, if you're isolated and lonely, that's not something that's going to respond to medication. Doesn't matter what dose or what medication. So it's recognizing, again, using a biopsychosocial expansive approach to treatment is recognizing that there is a role or asking ourselves, pardon me, what is the role of medication? What's the role of therapy? And what are important social factors that we could look to optimize? Because, holistically, there are many different avenues for treatment. So we should remind ourselves that you know it's not always trying the same thing and hoping for a different outcome, but being curious as to all the other aspects that can influence trauma and trauma recovery.
Amazing. Thank you so much, Dr. Ramasubbu. If you were to leave our audience with one piece, maybe they've been struggling, um, they're looking to start their own recovery journey. What would you share with them? What would be your message? Nothing but small questions for you today.
No, I think like I actually had chills when you asked that because I think for every person that I have the privilege of seeing and treating, they're probably just throwing out a number, but 10 other people that I'm not. And maybe there are individual or institutional societal barriers, stigma, maybe, an emphasis on resilience and self-reliance and in my population, service over self, just barriers that prevent people from showing up um, and seeking help, which is it's sad because I think in any condition which is more invisible than visible, suffering is experienced internally. And, I often see people years after their index trauma. So if someone is looking to get help, I can assure that the most important part is, you know, walking through the door, so to speak, and really showing up. And in my practice, once they're in my office, it's about establishing a sense of emotional safety and really allowing the individual to feel safe in sharing, being safe, feeling safe to be vulnerable, which is not an easy thing to do at all. But if there's anything that can be corrected in that experience, which might mean, Jonathan, that they're coming in with a preconceived notion that they're not going to be listened to or they're going to be dismissed. If you can alter that, if you can reframe that experience in a corrective way, so people walk out feeling like someone cares, I'm worth it. I can get better. They've already started the path to recovery. So just show up, and you don't need to go in with any expectations other than expect to be listened to and expect to be treated with kindness, respect, compassion. The rest will sort itself out, I would like to think.
It's amazing. Dr. Ramasubbu, I want to thank you so much for coming on the show today. Um, I know, even 40 minutes to look at some of these topics is not nearly enough, but it starts to scratch the surface. It starts to open up some more questions, and I look forward to asking you more of them in the future. So thank you so
Well,
much for that.
thank you so much for your time and for your advocacy as well, Jonathan. I do appreciate your role. Thank you.